3, 2, 1. Sir, we are live now.
Okay, so welcome everybody to today's webinar brought to you by the Orthopedic Research and Education Foundation. And today is really a continuation of an earlier webinar where Dr. Vikas Agashe from Mumbai, Hinduja Hospital, Mumbai, was discussing some very interesting cases. And so without much ado, I think we will get on with it. So over to you, Vikas.
Thank you, everybody. Thank you very much for the invitation. And so today, these are not unusual cases. This is something very, very common, a very common case. So let us start discussing. I'll present it first. And so this is a middle-aged person, known diabetic. He has a discharging sinus and he's been walking with walker. Clinically, he is afebrile, doesn't have much pain. His WBC, ASR, CRP are normal. I have traced the old X-rays. He had a segmental fracture 6 months ago, and open reduction with bone substitutes was done somewhere. He developed discharging sinus at 8 weeks, and he has been on multiple antibiotics since then. The sinus is persistent, and this is where he approached us. He carried this culture report. Now tell me, what would you like to do? This is the sinus. This is the adherent skin. What would you like to do? Manish Singh, would you like to have further imaging? Would you like to take a sample from the sinus? Would you like to explore immediately? Would you like to wait?
Participants, please unmute yourself. Yeah. Yes,
Sir, we can take a sample from the sinus, sir.
Okay.
And we can send for the culture.
Right. Everybody with him?
Anyone else?
Yes, sir.
Yeah, Adish, what would you do?
Sir, sir, I would like to treat him, check his medical parameters first of all, that whether his blood sugar and all is normal or not.
Okay.
Sir, and then I would go for, yes, sir. Sir, I would like to send the culture and all for, take the sample and then send it for culture.
You send, you take a culture swab and then send it for culture, is it?
Yes, sir.
Is that what we do normally?
No, sir. No, sir. No, sir.
Then why would you do that?
He doesn't agree with what you do.
Okay. Anyone else?
Yes.
I'd like to explore the wound and do a thorough wound debridement.
Okay. So would you do anything else before that?
So we could do a sinogram.
Sinogram. Okay. But anything else that you need to do before you plan surgery?
Is CRP and
Okay. Anything else? Which is probably really important in these chronic cases.
about the antibiotics, you will do anything?
Start
Sir,
antibiotics. Will you like to start antibiotics?
Sir, first we will stop antibiotics.
no, sir.
Okay.
Why? Why would you?
Because those antibiotics, that antibiotic can kill some bacteria or microorganism already present there, or that culture may become negative.
False
Yeah, okay.
positive case.
False
Or
positive.
false negative. False negative.
Okay, so the idea is that if the patient is on antibiotics, your cultures may not grow anything, even though there's infection. Okay, so you, as part of the workup, is to stop antibiotics, ideally for at least 2 weeks before you do your surgery, unless there's a fulminating infection and you need to give antibiotics for that. You would kind of stop antibiotics, make sure that you get your cultures from the tissue, and it's important to have stopped antibiotics to be able to get the correct cultures. Okay.
So what are the contraindications to this or exceptions to this policy
Yeah.
in orthopedics, not just fracture related, all the cases that you see as an orthopedic surgeon? When would you say, "Nay, I am continuing with antibiotics and I'm operating"?
Sir, if
Anybody?
we see that, so that the infection is very prominent at the site and signs of septicemia are present,
Correct, correct.
so then,
Anything
then I
else?
could not.
What do you mean is prominent at the site?
Sir, signs of inflammation are very much prominent.
So there's acute inflammation, and
Yes,
you
sir.
don't think you can wait for 2 weeks before you do your surgery. Okay.
Yes, sir.
Anything else? See, most of the soft tissue infections like necrotizing fasciitis, pyomyositis, very often come in a very fulminating stage.
Yeah.
And that is the time when you must aggressively debride as early as possible, even if they are on antibiotics. Rather, you also start antibiotics. Okay? And anything else? Somebody comes in at about, say, 3 weeks after, say, tibia nailing. Just giving you an example, or plating, tibia plating. And he has seen somebody earlier, and that surgeon has started antibiotics. Would you like to wait, or you would not like to wait? I am talking of at 3 weeks. He is on antibiotics for 1 week. Would you like to? So initially he has taken prophylactic antibiotics, then nothing has happened. And at about 2 weeks or 2 weeks, he has started collecting there. He goes to an orthopedic surgeon who starts antibiotics, and he sees you, the patient sees you 3 weeks after surgery and 1 week after starting antibiotics. Would you like to wait, or you would not like to wait?
So we
So
will
when
see
there
the
is-
symptoms
Yeah.
as subsided platelet level, or we will do ESR CRP. If that is in decreasing order, then we can wait.
So suppose there is a discharging sinus there. There is a sinus, or you can say discharge from the wound at 3 weeks. Patient is on antibiotics for a week. What would you do? Now
I
here
will
is
go
a
along with that.
little caveat that if you do not operate immediately, you lose that window period of about 6 to 8 weeks, isn't it? You wait for 2 weeks, then you may not be able to salvage the implant. Having said this, you may not have a culture positive. Then again, you will not be able to give culture specific antibiotics. So this is a little gray zone, but still, what would you do? I mean, I would go ahead and explore, because otherwise you might lose the chance of salvaging the implant. What would you do, John?
Yeah. I think at 3 weeks you have to go in, because you are still in that so-called acute, semi-acute phase where you want to
Correct.
Try to eradicate the infection and retain your implant. So I think
Correct. So I mean, even though we say a gray zone, we would definitely go ahead and explore.
So like just, I think last week we had a THR which we had done. It came back at when the suture was due to be removed, and he had a bit of a discharge coming. So instead of giving him antibiotics and waiting and things like that, we just went in and exploded, and he had a huge hematoma in the deep layer, which if he hadn't removed at that stage would have gone on to a fulminating and to a chronic infection.
Correct.
So you still have a chance of aborting the infection at that stage.
You are able to salvage,
salvage
that implant. Okay, now let me magnify this, and I would like someone to tell me the X-ray findings. I'll magnify it now. Okay. What do you see in this X-ray?
Adish,
So can you go full screen, please?
Oh, yes, I'll do that. I'll do that. 1 minute. I will just crop this also so that you are able to. Here we are.
So just look at the X-rays and describe what you're seeing. Simple as that.
So there is new reactive bone formation.
Would you like to start with that?
Start with
No, sir.
what you see now.
Yes, sir. Sir, this is an anteroposterior and a lateral view of bone of the leg, which shows tibia, part of tibia and fibula, with implant in situ, and fractures at the midshaft of tibia and fibula both, with some callus, and so probable it is at healing stage.
Is there anything else you want to talk about the fracture?
Sir, I can see the bridging callus has been formed.
yeah,
Anything else you want to say about the fracture? Is it it's a segmental fracture, isn't it? Which was mentioned
Yes, sir.
earlier. Yeah. So the tibia is a segmental fracture. So what is the problem with a segmental fracture, especially if it was an open fracture, as it was in this case? Can you see anything else on the X-rays? Can you see a lot of holes?
Yes, sir. Yes, sir. Sir, cloacae.
Very, what should I say, almost similar to each other. Barabar ki nahi? You
Yes,
think
sir.
they will be cloacae? See
Our
here, one,
cloacae is so
two,
symmetrically exactly the same.
No, sir. No, sir.
Then what do you think has happened there?
Sir, previous sites of screws, screw fixation.
So has Dr. Vikas told you that he's had some change in implant or anything like that?
no, he did not have a change in implant. So what must have happened?
The previous orthopedicians must have deliberately made holes in the bone so as to give way for the sinus to drain out.
So when do you think this was done?
Sir,
Once he formed the sinus or at the time he did the fixation?
sir, when he treated the sinus.
Well,
As I said,
yeah.
there has been no change in implant. Would anybody make such drill holes
Without changing the implant.
without changing the implant?
No, sir. No,
So
sir.
possibly the implant must have been changed, isn't it?
Yes, sir.
Have you ever seen anybody making a hole in the bone?
No, sir. Sir,
No.
not as of now. Sir, we
So-
do it. Yes, sir. Sir, we
Yes.
do it when we do cementing and all. But sir,
Cementing. So
sir,
when do you think you can do it? One is when you're looking for if there's any bleeding in the bone, okay? The second is if
Yes,
there's
sir.
pus and you want to let it out. Okay.
Yes, sir.
So here it's a situation where he's probably fixed it before there was pus. The pus has formed later. Okay. So it may
Yes,
have been
sir.
an open fracture where he wants to look at the vascularity. So he may have made drill holes, or in the hope that it becomes more vascular when you make the drill holes, which is probably not the most.
When we were children in orthopedics,
Yeah. Then we used to do things
many
like that.
people, for an exposed bone, drilling used to be done those days. Some granulation tissue would form, and then with the hope that we can put a split thickness graft. That's, of course, hardly ever done anymore. So probably the surgeon had tried to put a plate in that position, which did not work. So he changed the implant. Barabar ki nahi? They are almost similar holes. Correct?
Parallel, one line.
Okay, what else do you see? Sorry.
So
Yes,
What else do
Subhanshu.
you?
Yes, Subhanshu is also there, so we'll able to answer.
So does the
Amil?
bone look the same on top and bottom? And what about that piece of bone that is separate?
Yes, anyone?
Anterior to the plate.
Yes, Amil. Amil is also there. Okay.
No idea, sir.
See, what is this? Okay. Do you think alignment is okay? Is the alignment of tibia and fibula okay? Can you see
Yes,
this
sir.
is the proximal fragment
It's
and
not
that's the
perfect, but it's
middle fragment,
pretty
isn't
okay.
it? Huh?
Yeah.
And this is the
Bit of
proximal
reach
fragment. Barabar?
Yes, sir.
About the fibula also, that's the, sorry. This is the proximal fragment. This is the distal fragment.
Yes, sir.
So what kind of malalignment is there?
In fibula.
Both in tibia and
tibia and
fibula.
fibula.
And how significant is it? Is it something you need to do something about, or you can accept it?
It needs refixation.
Pardon? Speak
It needs
clearly.
Yes, Rajan.
सर refixation करना
Rajan is
पड़ेगा.
there.
You think it's not
Yes.
acceptable?
Okay. Now
First
you
is-
have a sinus. Now, do you think this is infected or not infected? And do you see any signs of infection? Radiological signs of infection.
So
Do
what
you
about
see any radiological signs of infection?
what about the top end of the sort of the segmental fragment? Do you think it's the bone looks normal? Yeah, where is
Does
pointing at the
this
moment?
does this bone look normal?
The top end looks as close.
Looks
There is-
sclerosed. Okay, finally. So
Yeah.
what does that suggest?
So dead bone.
Wow.
Now, do you see some reaction here? Now, do you see this? Can you see something here? I have magnified. So it is well away from the fracture site, isn't it? Barabar ki nahi? Also, do you see something here? See something here around this screw?
Do you think it's lysis or something else?
There is lysis.
So what does that suggest?
That is sickest.
No, lysis doesn't suggest sequestrum. Lysis suggests The screw is getting loose, okay?
Yes.
Sequestrum, the sclerosis can suggest dead bone.
So probably we have dead bone here. Agreed. We have lysis here. We have fluffy periosteal reaction here. So all that suggests that this portion is probably infected, correct?
Yes, sir.
As opposed to that, here you can see this is a bridging periosteal reaction and some kind of
Healing is taking place there.
healing is taking place here, correct?
Yeah.
So probably you have an infected non-union here and probably you have a healing fracture here, right? Rajan, you agree with me?
Yes, sir.
Okay. You also have some malalignment, right?
Yes, sir.
Okay. Now let's go further. So what we have decided, our diagnosis is infected non-union tibia of in a segmental fracture tibia with two-piece fracture of fibula with recurvatum in the at the proximal side with radiological changes of infection, correct?
Yes, sir.
This is where we are, right? Now, what is the advantage of taking? No, sorry, it's already 6 months. So do you think that by giving antibiotics, this would heal?
No, sir.
And what about the soft tissue?
You have,
The silence.
this is the soft tissue. All this part is adherent. This part is adherent to the bone. So you have a sinus, you have poor soft tissue, you have a fracture which has not united with X-ray changes of infection. So that means it's a reasonably advanced stage, correct? So it is
Yes.
very, very unlikely that it would heal with antibiotics, correct?
Yes.
So in
Yes.
short, you will not be able to salvage the implant. Barabar hai?
Yes, sir.
So when do you salvage the implant? Are there any guidelines? Are there any guidelines? So there are 4 things you have to remember. Number 1 is early. Like John sir said, around 6 weeks, 8 weeks is the maximum time, correct? Then you should have a stable fixation in reasonable alignment. Third is you should be able to get covering for the implant as well as the fracture site. And fourth is that is becoming more and more common now, is easy to treat, or there should
Organism.
not be difficult to treat organisms like non-tubercle mycobacteria, like fungus, like carbapenem resistant gram-negative organisms. If they are there, then very likely that you will have to take out the implant.
So what
these
was
are
the third point?
Soft tissue.
Soft tissue. Good soft tissue cover
Yes, sir.
for fracture site as well as implant, both.
Yes, sir. Yes, sir.
Okay? So these 4 things are absolutely necessary. The 4th, like carbapenem resistance, etc., you might be able to salvage the implant, but generally no. Added to that, there are definite risk factors. One is a nail, because you are often not able to debride well in a nail. And number 2 is history of open fracture. Because very often the point of entry is somewhere else, our approach is somewhere else. Samjha ki nahi? So chances
Yes,
of
sir.
salvage of implant in that are very, very rare. So we have come to the diagnosis. We also feel that it's already 6 months. There are signs of infection. So we will have to explore. Am I right?
And also host factors you should probably.
And host factors. Sorry. Diabetes, immunosuppressed, malnutrition. These are all increase the chances of non-salvage of implant. So here you would say that probably we will have to explore, correct?
Yes, sir.
Yes or no?
Yes, sir.
So you have signs of infection, you have non-union, you have a sinus. So that probable definitely becomes definite, correct? So how will you debribe this? How will you explore? How will you debribe? Can somebody draw the incision? Use annotation and draw the incision. See this annotation at the top? Take your cursor there and you click on this annotate. You will get pens of different sizes. You will get this thing, window to draw. So can somebody draw the incision?
Yes, Adis, you are able to see where is the
Yes, sir.
pen?
Yes, sir.
Just
Yes, sir.
click over that.
So on the left side, draw the incision where I have not marked. Try and draw it on this side. Try and draw it on this side. Okay, it doesn't matter. Okay. So everybody with him?
So what about the other side of the incision?
So you will go through the sinus.
Cross.
Yes, sir.
And cross the incision.
There is a eraser there. Erase the incision and somebody else can draw the incision.
Yes, Rajan.
Then I have drawn it in that green.
Green. So do it on other side.
Do it on this, the picture on the left as you face it. And make it a little more prominent than you have.
So through the
Yeah.
yes, sir.
So here along the shin.
Yes, sir. Through the previous scar mark and including the
Right. I'm not able to see.
Is made a thin line along.
Thin
the...
line, thin green line.
Who's drawn that?
Yeah, that's better, I think. Black one.
Who drew the black line and then withdrew it? Okay.
Rajan?
Manish.
Okay, do that. So don't.
Yes, Manish.
Sir, I'm drawing, but sir, it's not coming that correct, sir.
So you can
Do it.
make it thick.
View something like that.
Yeah.
Manish, sir.
Yeah, and then
Okay.
that's one side of it. Huh?
Anyone
Yes,
want to excise
so
the
basically,
sinus?
in most of these situations, you will
yes, sir.
excise the sinus, okay?
Yes.
And
So like
also
that.
excise.
And also some skin around it.
So essentially you will excise the sinus adherent scar. So that's your adherent skin. Now here distally, the skin is not that adherent. My drawing is little this thing. So it was almost linear.
Yeah.
Sir,
So-
will you go to the distal part also? Will you open the distal part also?
Yes. I'll just explain. Okay. Can you see this?
Yes, sir.
That's my incision. Now, whether to go distally or not is a bit of, you can say a bit controversial thing, but I felt that since I have two plates, one is definitely infected, I will definitely open the distal side. Because if that is infected and I don't open it, I'm in trouble. Plus, I thought the distal part is already healed. So there is no need to keep the implant. So if it is infected, then I have to address it. If it is healed, there is no problem. I take out the implant.
And
With
also,
that in
it
view-
would depend on what you plan to do in terms of the stabilization after your debridement.
Correct, correct.
And it depends if you have to excise bone, then how you would reconstruct the defect. So all these things would have to be thought of in your plan.
So this is what you have to plan. Your first step is create an uninfected envelope of soft tissues. For that, you have to have source control. That means you have to excise the skin which is not appropriate. Number two, you have to excise this soft tissues that are not appropriate. You have to take out the implant. You need to go underneath the implant and take out the biofilm that you would see. Then you need to address the bony, the bones, infected bone and the sequestrated bone or sclerotic bone, correct?
Yes,
So
sir.
that will be your base, source control. Once you have source control, you need to get a cover, correct?
Yes, sir.
In addition to that, you have to give culture-specific antibiotics, correct?
Yes, sir.
And stabilization is important. Managing diabetes is important. Giving good nutrition is important, correct?
Yes, sir.
Okay. So then you need to stabilize so that you maintain length, alignment, and rotation. And since you would be taking out the sclerotic bone, you'll have to add or generate bone. Correct?
Yes, sir.
What do you mean by generating bone?
So grafting.
Generate bone.
Would you graft in an infected situation?
No, sir. No, sir. Contraindicated.
Well, I wouldn't say contraindicated, but it's most situations you will not graft when there's active infection. Okay. So what
Yes, sir.
other thing can you do to get bone to grow there?
Sir,
So by dissection of the
So who's that? Speak a bit louder so that we can hear you.
So by using Lizaro,
Okay. So you do a distraction osteogenesis, which is bone transport. Okay.
yes.
yes, sir.
Okay. That's one. What else? What is the other technique?
Sir,
which
can
is,
we please,
Vascular
sir, a
technique.
cement spacer? Yes, sir.
Yeah. So that's the masculine technique. So those are your two main options in today's day and age. Okay.
Yes, sir.
And
Just
bone
one tip. Avoid saying Elizaro
Hmm.
for
Say
distraction.
bone
also, because
transport.
you
Yeah.
can use other fixators also, isn't it?
You can use LRS and whatever.
Barabar ki nahi? So
Yes, sir.
distraction osteogenesis is a very appropriate term.
Yes, sir.
Now, a bit about the incision. The incision has to go at right angles to the skin, and in this case should go up to the bone, because the periosteum here is also infected. So here you can see the whole thing is taken out with the sinus. That's after exposing both the plates. Very often these screw threads are there and they remain a source of infection. So beware, take out these threads. Be careful about this. Then this is after removal of the plate. You can see this is dirty granulation tissue. These are the holes and everything is filled. That's the fracture site, right? So just taking out the plate is not adequate. You need to expose the fracture site here. Can you see this granulation, infected granulation tissue?
Yes, sir.
And then that's the removal of sclerotic bone. Correct?
Yes, sir.
And then you have the full visualization of infected tissue. Correct? So just taking out implant removal for infection does not mean only implant removal. It means all these things. It means that take out the implant, take out the biofilm around the implant, approach the fracture site, approach the screw holes, approach the medullary cavity, all that. Okay?
Yes, sir.
So this is where we stand now. Now what do? I have taken out both the plates and I have a reasonably decent wound. Now what
So
do?
cement spacer and masculine technique.
Very good. Very good.
What about soft tissue? You think you can close that wound?
So
we
one
could go
basic
grafting.
requirement for masculate is to achieve good soft tissue cover. If you do not have a good soft tissue cover, don't try to put cement there.
Yes, sir.
Okay. So here, distally and part of proximal area, we could undermine the skin because we have made an excised the infected periosteum. So we could, here we applied negative pressure, that's the defect. And this I'll discuss later. And proximally and distally, we could close the skin aramse. Right? The middle part. Now this is where you would like to put the graft, correct?
Yes, sir.
Barabar, because there is a big defect. For that, as you rightly said, you would like to do masculate, correct?
Yes, sir.
Barabar? Now, you tell me about this. Did we discuss this anytime? About methicillin? No?
No, sir. Definitely no.
Acha, okay. So can anybody read this report? Can anybody read this report?
Sir, the culture report shows gram-positive cocci suggestive of Staphylococcus aureus, and which is resistant to ciprofloxacin and levofloxacin, and it is susceptible to most of the antibiotics, including gentamicin and erythromycin and clindamycin, linezolid, etc.
What is the first line of the culture report?
First line. So gram-positive cocci?
No, below that.
So culture aerobes.
Below that, I said.
So beta-lactam is
positive. So what does that mean?
Yes. So that it is beta-lactam is positive.
Then that group of
Beta-lactam is positive. Acha, sir. So the bacteria is probably it has the intrinsic activity of beta. Sir. So it has the enzyme to break beta-lactam antibiotics.
So So what was Vikas saying earlier?
What is this cefoxitin screen?
So it is a surrogate marker of sir.
You're
So
right.
some,
You're right.
You're right, it's being a surrogate marker, but of what?
sir. Sir, I forgot the drug name.
Having to
Okay.
think too much, no?
Sir, methicillin resistance.
Methylis. Yes, sir. Sir.
So what did he
Sorry.
just tell you? That they don't test methicillin resistance.
Yes.
They infer it by
Cefoxitin screen.
and the fact that it's producing beta lactamase. Okay.
Yes.
So why oxacillin? Why not methicillin? Methicillin is very unstable. So hardly anybody uses methicillin for finding out whether it is methicillin resistant or not. But they have kept that good old name. For some reason,
MRSA.
the microbiologists do not want to change that name. समझा कि नहीं?
Yes, sir.
They are married to methicillin. ऐसा. They don't want to change that name. And cefoxitin screen, actually in a colony of MRSA and MSSA, very often the MRSA can remain inert. While with cefoxitin, they get stimulated and can be cultured. So I generally say that, or our microbiologist has told me, as if you wake up the MRSA. They are sleeping with cefoxitin screen, you wake up these, correct?
Yes, sir.
So by suppose this was cefoxitin positive. If this was cefoxitin positive, yeah.
MRSA.
Yes, sir.
So what would that be called? This is positive.
So because it is a
And
surrogate
this
marker of
is-
methicillin,
and
we
this
could
is-
have called it MRSA.
If it
And
was
this is
resistant,
resistance.
yeah,
Yes, sir.
oxacillin
Correct.
resistant.
Now, how aggressive they become when they become MRSA? How aggressive? Suppose this patient has been having MHSA infection for 6 months, and on 7th month, he becomes MRSA. How
Yes, sir.
aggressive they become? I'll tell you. This is something which is not commonly discussed, that's why I'll tell you. Number one is with resistance, in fact, they become little less virulent. Most of the bacteria can become less virulent. But as regards staphylococci are concerned, generally MSSA does not become MRSA. They, like so many gram-negative organisms, will become resistant to more and more antibiotics. While MRSA are change of genetic pattern and they get infected with MRSA. It is not that because MSSA is not treated well, they become MRSA. No. Understand?
Yes, sir.
And most of the bacteria become less virulent with development of resistance. They definitely do not become more virulent. That is for sure. Okay. So what treatment will you give? What treatment will you give for? Now we know this is MSSA. So what treatment would you like to give? What antibiotics would you like to give? Do you like to start rifampicin? Would you like to start rifampicin? That's a very good drug for Staph aureus, isn't it? Very good, Dr.
Yes, sir.
Farias. Would you like to start rifampicin? So in short, when would you like to start rifampicin in the case of staphylococcal infections? Adish,
Yes, sir.
Rajan, Amil there. Amil has not talked.
No, sir. I don't know, sir.
Okay, anyone? Why is rifampicin important in staphylococci? It can penetrate biofilm of staphylococcus. Biofilm of staphylococcus. Okay.
Yes.
So it would work when the microbial load is less. When there are millions and millions of colonies, it would not work. When the colonies have come down drastically, it would work. Therefore, first and foremost, it is started only after the microbial load has gone down. That means you give some medicine for a week, 10 days, and then start rifampicin. Number two is it becomes resistance. The bacteria develop resistance to it in no time. Therefore, it always should be given with another antibiotic. Number three is there is no question of giving rifampicin because no biofilms. And last and foremost is it is generally given in higher doses. Now, one thing you should remember is, can you see rifampicin here? You don't see. So the microbiology society has decided that they will not give it any rifampicin, whether it is resistant or susceptible, in standard report. Because we being orthopedic surgeons, we like to interpret our own thing because we know everything about antibiotics. So moment you see rifampicin, you would start rifampicin. Without knowing these caveats, without knowing that rifampicin cannot be just given unless all these criteria are met. Therefore, they have decided in a nation like ours where COX incidence is very high, they have decided not to make rifampicin popular for staphylococcal infections. You need to ask. Suppose it's resistant to everything and you want to keep the implant. Then you have to ask the microbiologist, "Are baba ye jara kar lo."
Yes, sir.
Okay?
Yes, sir.
So here we gave Sizolin 2 weeks followed by oral cephalexin. Okay. Sasta or Sundar Dawa is this.
But you also use vancomycin in the beads.
Yes. Because you cannot mix
any
cephalosporins to stimulant. It becomes very powdery. Though vanco is not an ideal drug for MSSA, you are forced to use it.
But it will work with MSSA also because of the concentrations that you're using.
Yes.
And did you use PMMA or?
You can use it in PMMA, but you cannot use it in.
Did you use PMA?
Even there, it is thermolabile, so it is best not to use it.
We're talking about cephalosporins.
Yes.
Not vancomycin.
No. Cephalosporins. So here we use both because here in the middle we have to create a membrane, and proximally and distally we have closed. So we don't want to go there again. So we used biodegradable material here, stimulant, and we used the cement bead, cement spacer here, and
You could
put
close the
a-
wound.
we did a local rotation flap and closed the wound.
Yeah.
Unless you are able to close the wound, avoid putting cement. So this is where we are. Now question is, I have got a good envelope. Do I correct the angulation?
So one other question
Yeah.
which I would ask is, rather than create a defect like this, would you take off the excise the entire area and transport?
I mean, I had kept that in mind.
Okay. Because
In fact, that was my first plan. Only
but
thing
you,
is,
you
after
found that
I,
some of the bone was still viable, so you didn't do that.
yes,
Okay.
posteriorly, the bone was reasonably decent, viable, and did not appear infected.
Sure.
And then, of course, I cleaned the inner area, the medullary canal, etc. But this part of the bone appeared intact and decent. But then that was a chance that, I took. I agree. I mean, I had gone in with the idea of excising all this.
Hmm.
How would you like to correct the angulation? Anyone? Suppose I decide we have only 7-8 minutes. So just say, bolo. Would you like to correct the angulation?
Yes, sir.
Would
Why?
like to correct.
You think this angulation is significant?
Okay, suppose I decide to correct the angulation. What will be my procedure? I have not corrected, but I am just asking you. Suppose I decide, patient bolta hai X-ray mere ko aisa nahi mangta hai. I want an absolutely straight X-ray. So how will I correct the angulation? How will you correct the angulation? Anyone? What incision you will take? That's our incision. How will you correct the angulation? So in short, what I want to ask you is, will you address the tibia or you will address the tibia as well as fibula? Rather fibula and tibia in that sequence. And why? Barabar ki nahi? So if you have a malunited fibula with a significant angulation, unless you osteotomize the fibula, you will not be able to correct the angulation of tibia. Barabar ki nahi?
Yes, sir. Yes, sir. So
So
we have
that
to osteotomize the fibula first, and then we should
Correct.
go for tibia.
Perfect.
Because
Perfect. So what I felt was A, he is diabetic, B, his fibula is united well, C, his angulation is not that much.
And
So
also
I decided
you'll also destabilize that area
he
because
will
it's
correct.
got some kind of fibrous stability by now, and the
Correct.
moment you take
Correct.
that off, you're going to make it more unstable. So
it will be extremely unstable. So decided to just tide over the crisis as early as possible. So that's at about 6 weeks, we took out the opened this again, took out the cement and put in grafts. Now, one very important thing is, especially here, you can see the skin is just attached to the bone. You put more bone there. See, there is a defect here. Your bone should not be overstuffed.
yeah,
You understuff the bone. Otherwise, you will not be able to get a good closure. So here you can see at 6 weeks, this is understuffed. 6 months, but it has healed. This is understuffed, correct? But this diameter is reasonably good. And once you have a good cover, then the bone grows. What is that law? This is 1 year.
Wolf's law, sir.
Sorry?
Wolf's law.
Correct. Wolf's law. Wolf's law.
Yes.
So here you can see the defect is almost filled. Correct?
So there's one other problem in correcting the angulation is that you already have a bit of an equinus in that foot and you'll increase the equinus the moment you correct the angulation. See that?
No, actually, I don't have the dorsiflexion photograph. We had a decent movement.
Yeah, but it would increase when you correct it, you
Yes,
would get more
correct,
equinus.
Correct. You would get more equinus.
And probably lose some dorsiflexion in the bargain.
Yeah. So what is the take home? What is the take home from this case?
So firstly, so when to remove the implant and when to keep it.
Yes.
So then what antibiotics should be used and when to use rifampicin if even if we want to.
Correct.
Sir, and
let's start from the beginning.
First and most important thing.
In planning.
So let's start from beginning. Patient has walked in your consulting room. साहब
Yes,
6
sir.
महीना हो गया, पानी अभी भी आ रहा है.
Sir, first stop the antibiotic for 2 weeks before.
उसके पहले कुछ हिस्ट्री वगैरह लेंगे क्या? हिस्ट्री, एग्जामिनेशन, एक्सरेज, बराबर कि नहीं?
Yes, sir.
So what are the pointers? What are the important things you would like to find out?
Sir, X-ray report, blood reports, and any previous history of diabetes.
Glycemic.
Now, why say previous history? Why do you say previous history of diabetes?
Yes, sir. Diabetes. History of diabetes.
See, क्या होता है ना exam में especially? There's some people who like to, I should not use that term, but like to do this. And then they will catch you on these minor things. And then the entire discussion would go haywire.
Go towards there, yeah.
So history of diabetes. Then anything else you would like, any other history you would like to ask for? Anything else, any habits will you ask for?
So smoking.
Smoking.
Yes.
Is addicted to some substances. So alcohol and smoking, tobacco use.
Yes. Abhi, at this stage, I will just like to tell you one joke. A real thing that has happened to me. So one patient, a similar patient came to me, not this, but similar patient came to me. I asked him, diabetes, blood pressure, kuch hai kya? So he said, nahi sir. So I said, Baba, cigarette, bidi, tamaku, kuch hai kya? So he gets up like this. He put his hand in his pocket and he said, Sab, tamaku to hai, lekin aapko chalega kya mera? Anyway, so body and the habits. Then you have to examine him in detail. You have to, of course, take history whether the surgery was repeated, isn't it?
Yes, sir.
Then you are going to examine him. You see the sinus, whether it is attached to the bone or not. You see the adherent skin, correct? Then you
Yes,
come
sir.
to X-ray. What are the common findings on X-ray in infection? One is radiolucent line around the implants. One is periosteal reaction, either
Yes,
fluffy periosteal reaction or periosteal reaction away from the bone, correct? Away
Yes,
from
sir.
the fracture site. What else? A clear gap in the fracture site and a sclerotic both. Barabar?
Yes,
So
sir.
all this told us that he is infected. It's already 6 months. So we decided whether to keep implant or not. So what are the four or five important things about that?
So whether it is more than or less than 6 weeks.
Okay. So
Sir,
6
if
weeks
the
is not a real
alignment
cutoff.
There's no clear number, early stages. Okay.
Yes,
Let's
sir.
say early stages.
So
Okay.
second is alignment is proper, alignment is maintained or not.
Correct.
Stability of the implant.
Stability.
Okay.
Whether
Yes,
implant
sir.
is stable or not.
Yes, sir.
Alignment is there or not. Then
So third is whether the soft tissue coverage is adequate or not.
or you are able to achieve soft tissue coverage.
Yes, sir.
If
Yes,
the
sir.
plastic surgeon says कि he will not be able to give you cover, uska anterior tibial, posterior tibial, everything is gone. I will not like to do local slab. I will not like to do micro. समझा क्या नहीं? You should
Yes,
be able
sir.
to get cover. Then,
Sir, and fourth is whether the isolated organism is easy or tough to treat.
correct, very good. So you decided that it's already 6 months and you would like to take out the implant and explore. So
Yes,
what are
sir.
the importance we discussed in incision and debridement?
So first we have to take out the matlab skin which the tissue which is dead and the skin which is dead or adhered to the subbone.
Correct. Then
So then we can take out the sequestrate bone and then
नहीं, उसके
for
पहले
some,
implant है ना अपना, उसके पहले implant
अच्छा,
is there,
sir.
isn't it? So
Yes,
you
sir.
take out the implant, confirm that all the screws are out, confirm there are
Yes,
no those wires, I mean that thin thing inside, because that is something very common.
yes, sir.
Okay, or part of the screws. Then
Yes,
what
sir.
will you do? There is a
Sir,
film
exercise.
underneath. Yeah, sorry, go ahead.
Yes, sir. Yes, sir. Sir, we'll sir, biofilm or any kind of film is present or not, we should excise it and then we can send it for culture also.
So avoid saying biofilm because biofilm essentially are microscopic. So what you
Yes,
have to
sir.
say is slimy layer
Slimy layer.
suggestive
Yes.
of biofilms. Huh? Okay, after that, then you will explore the fracture site, correct?
Yes.
You will take out the sclerotic bone. Then you will take out the entire infected granulation tissue. Now here, the posterior cortex was intact. Very often the other cortex is not intact or is infected. In that case, you have to take that off. Then, especially in an open fracture, you may have a scar on the other side of your incision. You need to, very often you need to explore there.
Yes, sir.
Then one thing I forgot to mention is the drain side. Always see whether there was a drain, because generally from the incision to drain, there is a tract of infection. So you need to excise that. Okay. So you have done an adequate debridement. After that, we used negative pressure therapy so that
Yes, sir.
we had good granulation tissue and we could close proximal and distal part after 4 days. Correct?
Yes, sir. Yes, sir.
Then there was a defect.
Yes, sir.
So what did we do for the defect?
Sir, we could place the cement spacer in place with matlab, impregnated with adequate antibiotics like vancomycin.
Correct. And covered it, na? Covered it.
Yes, sir. Yes, sir. Yes, sir.
And then we took a decision about not doing anything for that minor angulation. Correct?
Yes, sir.
Right.
Okay. Right, Vikas. Excellent.
Okay. Bye.
I think
Thank you very much,
we are
sir.
a bit over
Bye,
time,
bye,
but I
bye.
think that was worth it. So thank you very much. And
Chalo.
I'm sure all the participants have gained a lot from this discussion, because I think it really goes through all the steps that one needs to follow when we are dealing with infected, especially post-implant infection, and what we today call trauma-related infections or fracture-related infections, FRI. Okay, so great. So
Okay.
until we meet again, bye everybody.
Thank you. Bye.
Thank
Bye.
you.
Bye.
Thanks.
Thank you very much, sir.
Sure.